Welcome, everybody. Thank you for attending. Thank you for your time. Delighted to welcome you to this webinar. My name is Sahil. I'm your chair and host for the webinar. And just waiting for a few more people to join us for a couple of minutes, just to allow. It normally takes a few minutes so that everybody can log on and safely see the screen, make sure everything is clear. We've got still quite a few people coming through. That's good. We'll just give it 30 seconds, I think, and thank you. Well, I think we've got a large chunk of people here already, so thank you very much, everybody. Welcome to this webinar hosted by LaingBuisson. My name is Sahil Mirza. I'm the author of this report, and my background is as a lawyer for a number of years, and I've been involved in the healthcare sector in terms of being a provider and in the recruitment sector, and as a writer over the last 2 decades, as well as working within the wellness industry within healthcare and the private sector. What we're going to do, just to lay the groundwork, I will do a presentation of the key points from the report, and then we'll be moving into an introduction from our panelists before we go to the questions and answer session. We've received quite a few questions already beforehand from attendees, and please, there's a Q&A function that will allow you to ask questions, and I'll do my best to get as many of those answered as we possibly can over the course of the next 1.25 hours. I'm very privileged to be able to chair this get together and this webinar. We've got a fantastic panel. Richard Mitchell, Chief Executive at Sherwood Forest Hospital's NHS Foundation Trust, is joining us, as is Maz Foch from Lincolnshire Community Health Services. Both very well-known chief executives, and I'm very privileged to say, contributed to their report with interviews. Neil Carberry is Chief Executive at the Recruitment and Employment Confederation, and Rachel Mackenzie is CEO at Retinue, who are the sponsors of this report. Without further ado, if we can just go to the next slide. I wanted to take, before I just go into the detail of the report, to take 30 seconds, if I may, to make a personal note. Most of you will be aware, yesterday the Select Committee reported their inquiry in terms of the burnout and resilience of the healthcare, NHS and social care workforce, which is at a challenging level, and I'm sure we'll be covering this. I wanted to take just 30 seconds to say that I've had very close members of my family in the first quarter of this year that have been in and out of hospital and received support in community settings as they battled with COVID. The world-class level of support that they got from all occupation groups and all care workers was magnificent. They are recovering, and I wanted to take this platform to say thank you to the workers in the NHS and social care for that, on a personal note. If we can go to the next slide. Healthcare workforce has now taken very much the center stage within what is really a revolution within healthcare here in the UK. If we look at the NHS, there's a whole raft of policy documents, from the 5-year forward view in 2014 to the long-term plan in 2019, changing the very shape and nature and models of care. The workforce is at a seminal moment, as is the whole system. And I've quoted there from the People Plan, the idea that there now needs to be a culture that puts that workforce in a center of a compassionate, inclusive culture. I've also taken time there to refer to the open letter sent from a number of leading providers within adult social care, calling on reform within the government's policy towards social care, so that this is really very much at the forefront of policymakers' minds, and very much in terms of practitioners and providers. The report is going to look over, really, if we go to the next slide, what we've done here is to look and estimate the level of spend agency use within the broad healthcare market in the UK. That includes the NHS, as you can see at the top. NHS England, £2.38 billion of spending. These are 2019-20 figures, and right down on the left-hand side, you will see that we have all of the different segments that comprise the healthcare field. Care homes towards the bottom are at £624 million. And what we haven't done is include permanent recruitment because of the inability to get accurate data here. It's very much the use of agency staff within all of these different settings across the healthcare landscape. And that is our estimate of the size of that spend at 2019/20. If we go to the next slide, which represents this in a slightly different form, you'll see that the dominant purchaser of these services is very much NHS England, and they comprise 55% of this market. But it's important to bear in mind that actually right across this whole piece, there has been a use of agency spend for many years within independent hospitals, within social care, and the devolved nations. Very important to bear that in mind. And just to give us a slight flavour of that different level of spend, the NHS in Scotland, for example, has seen a huge increase in agency spend over the last decade, particularly in nursing. And we'll come back and cover that in some detail. There is, in all likelihood, to have been a significant reduction within the NHS and within social care in the use of agency spend when we look over the last year in terms of the COVID. But the goal of the report is really to survey what that market looks like in normal times and what it's likely to look like as we move forward. If we go to the next slide, please. I wanted to step back a moment when we talk about agency spend. The recruitment sector, which of course are the conduit for the supply of temporary workforce to the NHS and to the private sector, including social care and independent hospitals, is a relatively poorly understood and perhaps misunderstood sector of the economy. These figures are from the ONS, estimating that the value of the recruitment sector stood at £59.5 billion in 2018. And just stepping behind the figures, we've very fortunate to have Neil Carberry, who is chief executive at the REC, that's the trade association for the sector. On any given day, the recruitment agencies in the UK place nearly 1 million people, 985,000 people in temporary assignments. This is in 2019, over 1 million people in permanent placements. And the industry employs approximately 119,000 people if we look at 2019 numbers. If we go to the next slide, just to look at the market slightly differently, the NHS in total comprises 70% in terms of being purchasers of agency supply. The dominant element, of course, being NHS England, as we've talked about earlier. The next largest segment as a standalone sector is the care home sector, which is 14%. And we go into a lot more detail within the report in terms of how this is broken down and the drivers. What I'm going to do here is to cover those two elements, NHS England and the care home sector, in a little bit more detail as an overview before we go into the Q&A. So if we could just go to the next slide and look at NHS agency spend. This is for England. And there are three, I think, quite striking points that I'd like to share. On the left-hand side of the slide, the figures start at 2000/2001. Agency spend has been ubiquitous within the NHS in England for 2 decades and longer. So it's not a new phenomenon. So we must be aware of that. Secondly, towards the middle of the slide, 2011-12 to 2015-16, we saw a precipitous rise in the use of agency spend in England. And there are a number of policy reasons for that, which we talk about in the report. This includes the Francis Review, which looked at the need for greater ratios in terms of nurses to patients following the Mid-Staffordshire scandal, and also policies of austerity, which saw record lows in terms of annual funding increases for the NHS. And the big backdrop, of course, is a rising set of demand for NHS services, aging population with complex demands. The other factor to bear in mind is that clinicians, nurses, and NHS workers were required to take de facto pay cuts in real terms during that period of austerity. The third point that I'd like to highlight is, of course, from 2015-16, we've seen a dramatic drop in the use of agency spend. And I'd like to elaborate on that if we go to the next slide. Looking at the absolute numbers now of spend and 2015-16 was the high point, £3.36 billion spent by the NHS in England on agency workers. That fell over the next 2 years by over a third, hitting 2.4 billion, and then stayed fairly steady over that period of 2 years to 2019-20. This coincides, of course, with the introduction of the agency rules. These were a market intervention promulgated by the predecessors of NHSI, Monitor and TDA. And what those rules imposed was a strict ceiling on the total value that trusts could spend on agency, also caps on the hourly rates, as well as a prescription in terms of the agencies that could be used on approved frameworks. And clearly, with that policy in mind, it's extremely important to see how successful that is. And it's at this point, I'd just like to point out that when the consultation document for those rules was issued in 2015, it was initially proposed that these rules would apply to both bank workers and agency workers. This was then rescinded so that it would apply only to agency workers. And I think it's an issue that will come up in the questions that it has already, and I'll return to, if I may, in a few moments. If we go to the next slide, just breaking down the spend, perhaps unsurprisingly, the medical and dental and nursing and midwifery occupation groups occupy the vast majority of NHS England spend, and that at 76% if we round it up. That hides the picture about what's happened in the 3 years preceding these 2019-20 figures. For medical and dental, we've seen a reduction of 12.7% in spending. But for nursing and midwifery, we've actually seen a 24% reduction in agency use. So the agency rules have clearly met the mischief that they were aimed at, which was to reduce agency spend. If we go to the next slide, I think it's important when we look at agency, the commentary around the use of agency spend is often placed within a vacuum, or just looking at that as a single standalone metric. We have to stand back and understand the decades history, the ubiquity of agency use within the wider policy context. When we look at the total level of full-time equivalent staff groups in NHS England over the 11-year period from 2009 to 2020, it's quite instructive. And we must remember the huge increase in demand for services, that between 2010 and 2015, there was a reduction in the total number of the NHS workforce. This, of course, coincided with the measures of austerity. We have seen growth in clinician numbers at the bottom in purple, 95,410. This is the medical group, has gone up to 122,000, so it's some 28% increase. But something to bear in mind, the next group, the nursing group, which is highlighted in orange, we've seen a growth in absolute numbers of less than 1% a year. So 9.8% growth in absolute terms from 2009 to 2020. And when, however brilliant the leaders in the NHS are, and I've been privileged enough as part of this report to have interviewed over 100 chief executives, HR directors and leads across the NHS, social care, voluntary sector and independent sector. Looking at the NHS, they have to deliver their services in the face of increasing demand within this macro context. And this is important to bear in mind when we move to the next slide, because if the numbers of staff is insufficient, we lead to the next slide, which is vacancies. Just wait for that to come up. And the demand, it's Health Education England in its note in 2017, Facing the Facts, was very candid in saying that there had been an absence of a workforce strategy for 25 years, and that there was a need to increase absolute numbers, despite the fact that they had grown, to meet this demand. Now, vacancies that arise are then filled predominantly through temporary work, whether that's bank work or agency work. What's instructive about this set of slides is that it starts in 2018, and that's an important year because I've talked about austerity and record lows in terms of increased funding in real terms for the NHS. That was reversed de facto by Theresa May, the then Prime Minister, in 2018 with a new settlement for the NHS, which saw an increase over the next 5 years of 3.4% in real terms, so substantially higher than the 1.6, 1.3 in previous years. although still lower than the overall average of 3.7 since the inception of the NHS. But despite that, and she was right in calling it a truly historic moment, because this was the background to the year that led to the interim people plan coming out and the long-term plan. If you look at the top line, which is the nursing vacancy rate, even as late as December 19, despite all of that settlement, we had vacancy rates of close to 1 in 8 roles, so 11.6%, 11.7%. And as we moved on the eve of the pandemic, the National Audit Office was stipulating that there were over 43,900 vacancies in nursing alone in the NHS as it entered that period, a year like no other, as Sir Simon Stephen has labelled it. If we go to the next slide, I just want to briefly look at the contrast. We've looked at NHS England. The devolved nations, the story has been quite a contrast. This shows the period over the 8 years from 2011 to 2019/20. England's compound average growth rate of spend on agency was only 1.5%, and that masks quite significant variations, of course, post 2015-16, where there's been a huge decrease in agency spend, as we've seen. By contrast, Scotland, Wales, and Northern Ireland have seen significant growth. And just to turn that into absolute numbers, I'll just quote Scotland, if I may. The numbers there, 11.3% as a compound rate, translates to a 135% increase in agency spend from 82.8 million in 2011-12 to 195 million in 2019/20. And nursing in particular there has gone from less than 5% of agency spend to 21%. So quite a significant difference in the nature of agency spend in Scotland. And all the nations, the devolved nations, leaving aside England for a moment, have issued draft or final plans for workforce. So this is certainly an issue that is being tackled, investigated, but I think it's instructive to see the divergence across the UK in agency use. If we can go to the next slide, before we go on to social care, I said at an earlier point that the agency rules, which led to the precipitous fall in the use of agency in NHS England, and that's represented, as you can see, in the orange here, which we saw agency spend fall from 3.6 billion to 2.38 in 2019/20. That, at the same time, we've seen spending on bank more than double, 115% increase. So we're seeing, quite interestingly, that the spend on temporary, non-substantive hours in terms of delivery of care has actually grown over the period of 2015-16 to 2019-20. And the question that some people are asking is, should the agency rules, bearing this in mind, if the mischief that the rules are designed to attack is the use of temporary work or expensive temporary work, should they be extended to bank workers? What is the true cost of an hour provided under a bank provision when we take into account, if they are substantively employed, the additional costs? So this is a question which we don't have definitive comparable data. We're hoping to get, and I think certainly from Neil representing the REC, it'll be interesting to get his insight. It's a question that has come up. But I thought it would be interesting to look at that contrast as we move now just onto the next slide to look at social care. And it's a very similar story up to 2019-20, high vacancy rates. This is across the entire adult social care spectrum of registered nurses and managers, 1 in 8, and even at care worker level, 1 in 12. Skills for care looked at 119,000 vacancies, a turnover rate of 30.8% towards the end of 2019. If we just move to the next slide, just to remind you, I'm going to break social care. I mean, obviously, it comprises home care, which is about 4% of the agency use market. Care homes are 14%. So I just want to focus on the care home market, if I may, for now, just to end this overview. If we go to the next slide, LaingBuisson has had decades of history and insight and expertise in the care home market, and our research shows us that agency staff, as a percentage of the total care home workforce for nurses, stands at around 18%, so very significant, and for non-care, non-nurse carers at 8%, and they comprise 14% of the total market. Just to go to the final slide, this is really to look ahead, what a slightly crystal ball version, but we've got experts on our panels who will be able to elaborate. I just wanted to break this down into the first 3 bullet points are what I've called the secular trends, the broader context in which to look at the use of agency and temporary work. All projections are showing globally a massive shortfall in healthcare workforce right across the developed nations. We're also seeing projections from the likes of the Health Foundation, etc., that we'll need substantially more workers in the NHS and in social care. The flexible meta trend, I think, is important to bear in mind when we look at agency away from purely the numbers. There is plenty of evidence, and the report goes through this in some detail, of looking at why clinicians and non-clinicians choose to work through agency on a temporary basis. It's part of a much broader trend in labour markets, which I'm sure we'll touch upon. And thirdly, the political economy of healthcare is a big determinant here of the use of agency and, in fact, the preference for agency, because despite the huge investment from the government, from the settlement in 2018, and now Boris Johnson's government in response to the pandemic, it's important to bear in mind that constraints in public expenditure do have an effect on the choices that people make in how they work. The classic example being the proposed rise in pay for nurses very recently, which has been met with some derision. Will that drive a desire, despite the fantastic work that's being done by brilliant leaders in the NHS, 2 of whom we have on our panel today, to make the culture of the NHS truly inclusive and compassionate as envisioned by the People Plan? The next 3 bullet points, which will definitely be covered in the panel, really talk about the immediate challenges. We have record numbers waiting hospital treatment. Some 400,000 people have waited for more than 12 months. Technology, there's been incredible innovation within the NHS over the last 15 months in response to how care is delivered. Will that have an impact in the levels of clinician numbers that we need? And disintermediation refers to the idea of a growing incidence where disruptive actors are in the field, matching clinicians primarily to shifts. Will that make a big difference? Wellness and inclusion are very topical in light of yesterday's announcement. And how are we going to ensure that those imperatives are met as we meet the demand for restoring hospital and indeed social care provision back to pre-pandemic levels? It is our view, based on these factors and the historical ubiquity of agency use, that it is likely over the next few years that the use of temporary workforce will remain very powerful within the NHS, within the social care and the wider healthcare market. I wanted to leave the final point relating to the statutory provisions that are going through Parliament seeking to install integrated care systems on a statutory basis. Those of us who've been around long enough to remember the dream of integration has been here for a very long time, but its predicate is that there is collaboration across all stakeholders in the system. And it may be perhaps, if we take a view of that collaboration, that all stakeholders in the workforce supply chain, substantive, bank and temporary workforce, if they can collaborate, perhaps we have a shot at meeting the growing patient demand for the world-class services that are provided by our healthcare service. Thank you very much for listening to me. The report is now available, and LaingBuisson will obviously be more than happy to hear your inquiries should you be interested in doing that. I'd like now, before we ask the questions, if I may, for the panelists to join with their screens and go behind a little bit and introduce themselves and the work that they do. If I may start with you, Richard, to have an introduction from you.
Hi, good afternoon, everyone. Thank you for the opportunity to join you today. So my name is Richard Mitchell. I'm the Chief Executive at Sherwood Forest Hospitals NHS Foundation Trust. We are a 3-site provider of acute hospital care in the East Midlands. And as Sahel was referencing integrated care, we work very closely with a range of NHS, local authority and voluntary service providers across the East Midlands.
Thank you, Richard. And Maz?
Hello everybody and welcome. I'm Maz Fosh, I'm Chief Exec at Lincolnshire Community Health Services. We provide community health services which covers home visiting, district nursing. We also provide sexual health services within Lincolnshire, urgent treatment centres and specialist services. So a real array. We are front and centre in the community and work with all our system partners. Thank you.
Thank you, Maz. And Neil?
Afternoon, everyone. I'm Neil Carberry. I'm Chief Executive of the Recruitment and Employment Confederation. We're the professional and trade body for recruitment and staffing businesses here in the UK, and we have about 3,300 members helping all sorts of sectors in the UK, but clearly, as you've just heard from Sahel, healthcare is a big part of that.
Thank you very much. And Rachel?
Thanks, Sahel, and hello, everyone. I am Rachel Mackenzie. I'm the founder and chief executive of Retinue. We're a specialist workforce solutions provider in the health and care space. I'm a lawyer by background, but my passion is definitely people, two things that don't always go together. And really delighted to be here today talking about what I think is the biggest challenge at the moment faced by the health and social care sectors. It's people, it's workforce, retention, recruitment, blend of permanent, agency and bank. So some really meaty topics to get into.
Thank you very much. I know we've got some questions now are beginning to fill the chat here, which I will absolutely get around to. But prior to the commencement of the webinar, we had lots of questions. People were kind enough to stipulate as they registered, and they fall into a number of groups. So I'm going to start with the first one. And in light of yesterday's comments from the Select Committee, I think that we can really we've got a tremendous backlog of work to do, a workforce that's absolutely been heroic across the entire piece of the healthcare sector, but whose wellness and well-being clearly, according to the report, are at a challenging level. And I just wanted to really get the panel's view on how we're going to balance and square that circle, meeting demands, meeting expectation, and still looking after the well-being and wellness of the workforce. Richard, if I may start with you, I know this is a very passionate topic for you. You've been on record as saying kindness is a key variable in the delivery of safe patient care, and that well-being is a golden thread that runs through all the work that you do with your colleagues at Sherwood Forest.
Thank you. Yes, I hope all of that is true and that we've got evidence to support that. Certainly, as you suggested, I think the welfare and the well-being of our colleagues has never been so important. We know that the last sort of 15 to 16 months with COVID in our organisations and across our personal lives has had a massive impact on lots of us. We've got very shared experiences and we've got very personal experiences. As the chief exec of a hospital, I worry about three things, and one of them certainly is the welfare and well-being of our colleagues. And what we're seeing at the moment, unfortunately, is as colleagues beginning to have serious impacts on their mental health as a result of their experiences over the last 12 months. And we're fortunate that we are able to support them and to enable them to access specialist services. I firmly believe, and I think lots of us firmly believe, that the only way that we will be able to meaningfully restore our services over the coming months and coming years is to focus on the welfare and well-being of our colleagues. I think collectively we've put a lot of effort into psychological support, and at Sherwood we're very fortunate that one of the health organisations that we work with is Nottinghamshire Healthcare Trust, who provide mental health care. And they've provided us with some exceptional support that will continue. I think across the public sector, we need to get more effective at sharing best practice and asking for help. And I think that ties back to the point about that integrated care working. I also think, though, as well as that sort of psychological support that certainly will be needed, I would volunteer that we need to relentlessly focus on doing the basics well, and that may tie into your point, Sahel, about kindness here. I think if you talk to people, if you listen to people and you thematically understand what do people want out of their working life, I think it falls into, broadly speaking, four things. The first thing is they want to work for someone and work with for someone and with someone who's going to support them, look after them, encourage them. The second thing is I believe they want to work in a team who will make them feel truly included. The third bit is they want to work within a team and an organisation with safe staffing levels, and we may explore that later. And then finally, they need to be able to have meaningful rest and breaks. And I think a combination of that and a combination of the excellent psychological support that's evolved over the last couple of years does offer us a way forwards.
Thank you very much for that, Richard. If I can go to Maz next, you're one of a very select group of chief executives in the NHS with a professional background in HR and more than 20 years in, including outside the NHS. And obviously Lincolnshire community, I'm well aware, has got one of the highest response rates when it comes to the NHS staff survey. Just wanted to get your feedback on this critically important point, because unless we deal with the wellness and well-being, we won't be able to deliver the vision of the long-term plan.
Yeah, absolutely, and totally concur with Richard. This is about how do we take care of our people, and I think one of the key things that we've got to understand, there is not one fix for all. People are going to recover at different stages and phases. Some may feel absolutely fine now and be hit later along down the line. And I think the key bit in all of this is, we're talking about human beings who absolutely have a life outside of their job, their professional world, and have families and friends who equally, I don't think there's anybody that any of us has probably spoken to that hasn't been impacted by COVID-19. And I think that is the reality that we are working in. Some people do and will need psychological support. Some people will need support from that team. And don't underestimate the conditions that Rich has just talked about that actually create a great place to work for people. And part of that is kindness to each other and recognising when people do need to have a meaningful break and rest. And I think that's going to be the challenge and balance for us as we move into continuing to respond to COVID-19. It has not gone away. But also as we restore services. And one of the things that I'm really keen about is we really talk and hear about waiting lists, and I'm sure we'll come on to that at some point later on, but also there's other services that are continuing to restore. Within our social care sector and voluntary and third sector, we have areas that aren't restoring are no longer able to continue to function, and that will impact on us all, and they're the things that we do need to take consideration as we move into working as ICSs and in partnerships with each other.
Thank you for that, and I completely agree in terms of the importance of the voluntary and social care elements of the landscape. As you know, we've been privileged to interview many leaders from those fields, and they play a critical role, without which the NHS simply wouldn't be able to deliver what it envisions doing. Rachel, just thought I want to touch base with you, because obviously Retinue work with a broad range of providers across the healthcare piece, and what you've seen when it comes to well-being and the supply chain.
Yeah, absolutely. I think sadly the report findings yesterday are unlikely to be a big surprise to anyone. The issue of burnout across health and social care colleagues is not a new one. It's something we've been talking about for a long period of time. And we're talking about a workforce, about people, as Maz rightly says, that 15 months ago was already fragile. This is around 3 million people across health and social care that have gone through unimaginable trauma in both their professional and often their personal lives, who've had to find the resilience to cope with significant and sustained change at work. And we underestimate that often. And whose actions and efforts in a lot of instances now will be scrutinised through different inquiries. And, you know, over the coming months and years, we've got to protect that workforce and make sure particularly that not only do we support them, but there isn't an apportionment of blame on individuals within the workforce. That fear, I think, is already driving attrition and driving feedback from those workforces that they don't want to be part of that. And I think that the report yesterday, the definitions for me and the descriptions of the workplace burnout were actually really surprisingly helpful. As I think was the kind of link between staff wellbeing and patient experience, and bringing it right back to what's important. It's about the patient as well as the staff. And the report recognises that chronic stress that the teams were subject to wasn't successfully managed in lots of instances, and there's a huge plethora of reasons for that. But we must ensure over the next month, few months and years, that support is put in place. And I guess to your point, Maz, that support must be personalised. and it really must be accessible. We're working with a number of organisations at the moment to make sure that the support isn't kind of offered as a platitude, and that it's genuinely accessible, not to those who are just permanently employed, so to the voluntary workforce, the flexible workforce, but also to those that don't necessarily have a propensity to access support services already. The support has to be promoted and accessible within a range of different arenas, so that issue of burnout and the importance of wellbeing is properly highlighted to people. And I don't think, you know, we're working with some organisations where there's some great practice going on, but I think a lot of organisations, unfortunately, are still in reaction mode and still trying to work out what best practice looks like.
I think, as you say, I think this is going to be an issue that's going to be forefront and centre over the next months and indeed longer. Neil, might be a good opportunity. Obviously, you've been very close to policymakers during the pandemic, and just wanted to get your perspective in terms of some of your members, and obviously they supplied a broad range of occupation groups during this whole pandemic, and the wellness issue is clearly going to be a very important part for them to address.
I think that's absolutely right, Sahil. And I'd just like to start by saying that I think I feel very heartened about what we've just heard from Richard and Maz and Rachel, that people are thinking in the service in the right way about this. And certainly, you know, one of the aspects that many agency staff have said, people working for our members have said, is they were doing a lot of work during the pandemic in terms of meeting demand, but actually they were also doing a lot of work as a shoulder to lean on with members of staff when they were working out how to make things work. And I think everything that we've heard from the other panelists is really important, no matter what form of engagement you have with the health and social care system. And you know, there's one thing I think we all need to do. I think it's where you were at the tail end of the report, Sahil, which is ultimately, agency spend is just people's wages. The wage bill in Richard's Trust is people's wages. We're dealing with humans wherever we look. And some of this is about how we help people process what has just happened. We know that humans deal with trauma after the trauma has been dispensed with. So the next period is really important. But some of it is also about the meta trends that you pointed out in the report, Sahil. It's about the fact that if we don't want to get back here, what can we do, whether that's agency, bank, or substantive staff, to help staff feel they have control of their working lives, that they have choices, that and that might require, in all forms of engagement of staff, some quite difficult changes to things which have been established for a long time. But I think this is a moment to be up for that debate.
And I'm sure we're going to explore that as we go along. One of the other, I'm just bunching some of the questions here that have come through and pre-webinar, and one of the obvious ones, just looking at nursing, it seems to be quite a big point here. Big vacancy, 43,950, National Audit Office on the eve of the pandemic. Those numbers have changed, but as we now restore, the question is, how are we going to ensure that we have sufficient numbers of, it says nurses here, but we can broaden that, to meet the demand across the healthcare system. So if I can start with Maz on that one, because you obviously look at a whole community perspective, not just on an acute setting.
Thank you. And I think it's really key that we don't just look in one area for our future workforce. I think it's the blended approach of our domestic pipeline. And I think one of the things that we've talked very candidly about the health and well-being of our workforce just now, but also let's not lose sight of the real positives that COVID has brought for us. I have spoken to many healthcare professionals who have felt immensely proud about what they have delivered during the last 18 months, and it has reignited and re-energized. And I think that's something that we need to continue to do in health and care, to really promote the future careers of health and social care for the future generations of actually it is a meaningful profession, vocation. I think there's something about our domestic pipeline that actually we encourage, we support, and we train effectively. We encourage and continue to work and ensure that people are working at the top of their profession and that they are able to carry out meaningful roles. We've also got the unregistered workforce, and I think this is our absolute tapped in area that we've got to focus on. And I shall give some live examples of the work that we're doing as a system in Lincolnshire. We went out for apprentice nurse associate roles, and we were inundated with applications, and that's fantastic, far more than what we ever would be able to take as placements. So what we didn't just say thanks but no thanks. We asked them if they would be interested in getting some experience in different sectors, and we forwarded those to our Lincolnshire Care Association, who oversees care homes, domiciliary care, community day supports, and absolutely really thinking about working together around actually how can we grow our own, and if we can work together as a system in thinking around how do we encourage those people to step into health and care, how do we then provide them with the right career paths? Not everybody is privileged enough to be able to go to university. I certainly didn't go to university after leaving school, and I think that's really important that we use apprenticeship schemes to help people to get their degree and to go into registered professions or where they want to go, and I think that's a key bit. The other area is international, and I think I'm not going to shy away from this. I feel sometimes I sit here with two sides of a very difficult coin at the moment with what we have seen during the pandemic, particularly in countries like India, where we have seen healthcare systems just collapse under the pressure. However, we still do have people who want to come and work, and have people in our pipelines across the NHS to come and work with us, and it's how do we continue to support them if that's what they want to do, to come and work in our systems and in our organisations. But also we've got to be mindful, you know, we are talking about us here in this country about the workforce shortages. This is a global shortage of workforce, and there's got to be something absolutely that is taken at the highest possible level in each country government around how we ensure that we are all providing the right numbers of people to be able to deliver the care that we need in the future. And then just finally on that for me, technology has a place in all of this. This isn't just about getting people into posts. We've got to create new roles, and I think allowing people to work at the top of the profession and upskilling our unregistered workforce is absolutely critical. But we've also got to be digital savvy and use technology to take over and take some of those tasks off that actually could be done by a piece of kit. That is going to free up our workforce and actually give people much more time with front and centre with the patient.
No, thank you for that, and clearly it's going to be a multivalent approach in terms of attraction and retention. Rachel, if I may ask, picking up the technology point, but really looking at that nursing curation of the supply chain, we have a short-term demand imperative. There's a number of things that Maz has talked about. What are you seeing in terms of the market and the approaches that are being taken?
Yeah, I mean, there are a number of facets to addressing the workforce shortage. It's a complex area to untangle, and to be honest, if there's a silver bullet, somebody would have definitely fired it by now. As Baz says, it's a global challenge. I think it's always worth stepping back and thinking about the outcome that we're trying to achieve, and the outcome that every healthcare professional is seeking is safe patient care. And I think the healthcare sector has done a great job recently in recognising that workforce optimisation is just as important as recruitment and retention. And that's reflected in the growth of things like telehealth, the improved use of healthcare professionals based outside of the UK or outside of the US, as well as AI. I think changes to and streamlining of patient pathways and the creation of new roles that will support the changes in the demand profile and volumes and the care delivery required over coming decades are critical. But kind of taking the point back specifically to the people shortages, I guess, for a moment. In terms of healthcare resourcing, there are two important principles that we work to with most of our organisations. The first really is supply chain augmentation rather than consolidation. That concept that talent acquisition needs to be viewed holistically across permanent workers and flexible workers, and every single available channel needs to have reach and has got to be optimized. And that includes internal mobility, it's the digital sourcing and the use of technology for, you know, digital attraction campaigns, better use of technology to reach more people, optimization and extension of all of the domestic recruitment channels and the international recruitment channels that are available. And we need to think about, you know, how do we provide attractive, flexible working opportunities for people. And the second point that we regularly talk to people about is EVP and the link to employee shortages. So if you think about employer value proposition, on the global stage, the NHS is one of the largest and has traditionally been one of the most prestigious employers globally. I agree with Maz, the pandemic's raised the profile of health and social care professionals enormously, and we talked to lots of people about re-entry into the sector as well as training opportunities within the sector. But we do need to be conscious that the kind of brand United Kingdom in some arenas has definitely been impacted by some recent events, including Brexit. The strength of the pound for international workers is weaker than it has been in prior years. And there's lots of fairly shiny and exciting opportunities for international workers to be elsewhere. So we need to work really hard to make sure that the NHS remains an attractive place to come and work or to stay and work. And it's both of those points. It's about recruitment and retention. And then I guess at a country level, I think lots of organisations assume that a doctor or a nurse or a support worker or a finance director will just find them. And we've got to recognise that candidates have got an almost limitless opportunity at the moment. The recruitment market is booming. There's significant shortages, not just within healthcare professionals, but across lots of professions. And as an organisation, we've got to be able to clearly articulate why a candidate wants to come and work for that specific organisation. And then secondly, we've got to make sure we reach them with that message. And they're not easy areas to unpick and make sure that we're absolutely focusing on. And there is, in my view, a role for lots of parties in that, whether it's digital marketing, whether it's job boards, whether it's agencies, whether it's bank providers, whether it's international partners. That supply chain needs to be augmented rather than consolidated at the moment. And that's a big piece of work for organisations to think about.
Thank you for that. Richard, this is obviously a big topic. Just trying to narrow it, you're obviously very much involved in the leadership in terms of the integrated approach. Is part of the answer, or clear part of the answer in terms of staff shortages, particularly nursing, a regional approach, an integrated care system, systems level approach?
Yes, so certainly I think integration does provide a big opportunity here, as described, whether it is about working as a region to bring people into your region, or as I think it was Maz earlier reflecting about organisations working together, giving people the opportunities to have greater flexibility in their roles. Certainly as a secondary care provider, one of the things we're looking at is closer working with primary care and giving people sort of variety to their jobs that they may not have had previously. I agree, just taking that on an extension though, I agree with the points that colleagues have made. Just one thing I'd like to tease out slightly further though, if I may, is about the importance of retention. Because whilst we're in a challenged situation, I certainly think we need to be focusing on the sustainability and stabilising our workforce before, as part of that process then of strengthening the recruitment. So in terms of retention, I think it's about making people's working lives as good as they can possibly be. And I touched on some of those things earlier, probably just a couple of the strands to pull out in a bit more detail. One of them is about that sense of inclusion at work, and whether you are a doctor or nurse, or you work in HR or management, or on Monday we were spending some time listening and engaging with our healthcare support workers. I think irrespective of your role in an organisation, a sense of inclusion is more likely for you to want to feel retained and to stay in the organisation. I also think as we move into restoration, we're going to expect people to deliver a huge amount of change, and change can be difficult for reasons that we understand. So I think the people who we need to deliver the change need to be involved in the inception of those conversations. If I get told something, just do this, I may have an issue with it. If I feel that I've been involved organically in the shaping of the decision and I really understand why I'm being asked to do it, I think it's more likely that that change will work. And then finally, there's a phrase that we've probably all heard, that trust dictates the pace of change. I think given the complexities of our working and our personal lives, whether it's working in one organisation or spanning across the system in terms of integrated care, all of us need to focus as much as we can do on building that trust with the workforce who we support and are working with. If you view life through the idea of positive intent, as I do, which is good people come to work to do a good job, we just need to support them. And once you can do that, I think you unlock a huge amount of potential.
Thank you for that. As you say, recruitment initiatives, international, domestic or otherwise, are going to be incredibly important. But if we don't keep our eyes firmly on retention, it's going to be self-defeating. Neil, just wanted to touch a base. Obviously, there are global shortages. This drives the market. This drives decisions for people to work flexibly. You at the RSC have produced research papers on that flexibility trend. Just wanted to see what your members are seeing in terms of that shortfall and how they're playing a role in that.
Well, I think it's increasingly obvious that that point we've heard about optimization and augmenting the supply chain is very current amongst our members right now. At least impartially, you talked about the effect of the agency rules on our part of the world. One of the things that's interesting about the agency rules, which have clearly achieved their goal, looking at your report, is that by comparison in other sectors, people come to us to manage, to achieve productivity, to reduce costs next to what they achieve, i.e. to develop some of the optimization that Rachel was talking about. And I think the difference is that what we've done with the agency rules is very focused on reducing cost per hour of each placement. It's not actually very focused on optimization. And maybe, I know you're a polymath, Suhail, so you'll like this. Maybe we need to refer back to Article 427 of the Treaty of Versailles, which says that labour is not merely a commodity or a matter of commerce. Going to Richard's point, we are dealing with human beings here, and a lot of what I think the sector as a sustainable part of a wider solution can offer into health and social care is exactly what Rachel was talking about. It's that sense of what we've got now isn't quite working for the goals that the NHS and care providers want to achieve. How do we pitch a big tent and start having discussions that aren't about, you guys charge too much, you guys don't charge enough, why can't you fill my nurse vacancies? And increasingly filling vacancies is difficult in the sector because the framework rates haven't moved on in a number of years, and medical staff have choice, especially at a moment like this. So there's a moment here for exactly that bigger discussion about how do we optimize for a substantive staff, but also for staff who are working on a temporary basis, whether that's coming through a bank or through an agency.
No, I wonder if I can just thank you for that. I think pertinent to that was just you picking up the flexibility point here. We have different approaches over the flexible market, people choosing to work, whether that's and flexibility now built in, of course, from the people plan. One of the challenges with that, particularly when we're being provisioned through an agency environment, is, and this has been picked up politically in the last week or two, is a question of reputational risk, financial risk, and compliance with very complex legislation, IR35, all of these type of things. Obviously, that was extended into the public sector, the NHS, 4 years ago. It's now gone to the private sector. Just wonder if you can pick up on that point, because that's one of the big things when we're looking at agency. We've got chief executives here who stand at the end of the day with their reputation and risk in terms of if we're going to have flexible working and that includes agency working, how are we going to ensure that that supply chain is compliant and meets the values of the NHS and indeed social care?
Supply chain due diligence is the issue of the moment, and I'm delighted that it is, because my flippant answer, of course, is use an REC member. My less flippant answer is that you as the senior contracting body do need to be paying attention to what is happening in the supply chain. And one of the things that keeps me awake at night is some of the technology platforms we're seeing develop are fantastic, and they will do great things for the NHS. Some of them are employment agencies, should be complying with the 1973 Employment Agencies Act, should be complying with the 2003 conduct regs. Not sure that they are. So there is a point there about supply chain due diligence. And I think one of the big roles for people like the framework providers going forward is working out how we move from price to value in what we do. And part of that is about making sure absolutely that the taxpayer gets value in what we supply, but also actually how we can reassure people like Maz and Richard that in working with providers, they are getting a level of supply chain compliance that gives them confidence on everything from tax compliance through to, at the worst extremes, modern slavery.
Thank you. Richard, if I can pick up on the wider picture around the agency, not the minutiae of the tax rules, but this is an important point for a trust in terms of the workforce, substantive, bank and agency. And that's a big point. Are you seeing trends towards technology, that those type of platforms which you see a reduced need for agency use, or is it more of a holistic approach depending on clinicians' preferences about how they work?
I think agency has a key role to play in the provision of safe, high quality care to patients in the NHS. But clearly it works in parallel along with employment of substantive colleagues and also bank colleagues. In the organisation I work in over the last couple of years, we've seen a movement from agency, smaller proportions of agency now to a greater use of bank and a greater ability to employ colleagues substantively. I don't think we will fully stop our use of agency because, as I say, it's an important contributor and it gives us a level of flexibility. I think changes in technology will change the way in which the workforce works in the future and our requirements for workforce. But as we touched on earlier, the demand coming into the NHS and other public services is increasing as well. So whether the technology enables us to buy out some of that demand, I think that's for a point we could debate in detail for much longer. So agency is important, but it is only one of the parts of our overall workforce, and we would always look ideally to work in partnership with other organisations to offer people substantive roles in our organisation.
Thank you for that. Rachel, I wanted to pick up because obviously Retinue work with a number of providers of temporary workforce and work with across the NHS and social care. I just wanted to pick up this point around risk and ensuring that compliance is paramount for safe delivery of care and for patient care.
Yeah, absolutely. And it's one of the things that certainly keeps a lot of our kind of chief people officers and CFOs and medical directors and nursing directors awake at night. You know, the complexity around things like pre-employment checks have to some degree been resolved by frameworks and audit processes, and from a safeguarding perspective are far superior to where they were 15 years ago. But if you look at things like modern slavery, particularly in the social care sector, it genuinely remains a real risk. And there's lots of organisations working very hard as either bank providers or agency providers to ensure that that risk is minimised. And to Neil's point on the umbrella risk, I find it terrifying that the opacity in that risk and the lack of understanding of that risk to the hirer and the end user of temporary staff is just not visible at the moment. And it's a real risk. And if you look at the emergence of the umbrella schemes, mini umbrellas, unscrupulous umbrellas, we process 18,000 payments to workers on behalf of NHS trusts every single week directly. We indirectly manage 580 suppliers of different flexible workers across sectors. And we do a huge amount in terms of audit of the actual pay vehicles for the candidates. And it's not unusual for us to see a band 5 nurse being paid £1,500 through an agency. The agency is then processing that payment through an umbrella, and perhaps £100 of that is accounted for as PAYE taxes. And some of that risk flows directly back up the supply chain to the hirer. And that risk at the moment, without technology, without supply chain management in operation, creating some visibility and control, is impossible to see. And it's something that at the moment, I know Neil and the REC are doing quite a lot of lobbying with both members and with the government around. HMRC need to make some decisions on it and actually help the sector get to grips with it. And we're driving some debate with the frameworks at the moment to try and say, what are you going to do to help the customers? Because none of us can address this on our own, but it's a material risk in the sector at the moment.
Thank you for that. I'm very conscious of time. We've probably got one more question, and then we're going to wrap up. I know that at least two of the panelists, if not more, have got urgent meeting coming up on the in the next 15 minutes, 10 minutes. I wanted to broaden the picture on a topic. It's coming up here regularly in the questions that I'm seeing here, and it's been in part of the zeitgeist for 15 months, and that's the question of inclusion, equality and diversity. It's come out in terms of the disproportionate effect of COVID, of course, but also as part of a key element in the NHS and the wider workforce. I think it is a nexus between wellness and inclusion. Maz, you touched upon it earlier, and I just thought we can come to you with some of the work that you're doing as an outstanding rated trust from CQC. How important is getting that right in terms of this whole equation, in terms of loyalty and retaining people? Without getting that correct has got to be a central part of the solution.
Absolutely, and it's about belonging, isn't it? At the end of the day, it is about everybody belonging, and I think we still have an awful lot of work to do. And I say that as somebody who sits here in a previous life who has been a diversity manager. I am a leader who will be very open and honest and say, I know many things, but I am also learning and will learn and need to learn with colleagues. I think the key bit for me is around lived experience and really understanding. So we might look at it from a perspective of, we think we have all the right processes and policies in place, but actually there's nothing that can make it become more real than hearing people's lived experiences. And that's from how they may be perceived and received from a member of the public, a patient, a client, through to how organisations may not understand nuances of different cultures, or how things do not feel as accessible to the majority. And I think we have a huge role to play. I think COVID has brought it front and centre, along with Black Lives Matter. And I think what it also did is shine a light on, we're not as far forward as we really think we are as a society, and we still have a lot of work to do. And I suppose from my organisation and from the Lincolnshire system, we're really working together. We've set up a Black, Asian and Minority and Allies Network Forum, which not only is for NHS, it is for the whole ICS colleagues to be part of. And we need to learn together. We need to hear lived experiences. And I think there's something about, we sometimes can be really good as well about new starters and those people who are joining, but we forget people who have been working in the NHS for the last 30 years, and we've not really stopped and listened to what their lived experience is. So I think it is about, how do we make inclusion? And I think part of that, it comes back to recruitment and the things that we've talked about. Flexibility is going to have to be a real key for us, and learning together. So not everybody wants to work the same way. Not everybody, we all have different needs. And I think that's the key bit around how we retain staff. We've got to pick all this up together, but absolutely be really clear that actually inclusion is about, how do we make every team member feel that they belong into an organisation or into a system.
No, thank you very much indeed. I've got 7 or 8 minutes left. Neil, I know just again briefly, your members have been working on this field, and you've produced an audit looking at this whole question within the recruitment sector, or undertaking that. Just thought I'd get your views, particularly given your broader roles, of course, with ACAS, etc., which promotes good working environment, of course, across the whole labour market.
I think I started today talking with a group of FTSE 100 chief executives about this, and they were talking about the kind of the language of the private sector has moved from towards reach on this, race, ethnicity, and cultural heritage, and the two things that they were very focused on is, one, listening, exactly as Maz was saying, to people's lived experience, and listening to it right at the top of the organisation is really important and powerful. And the NHS is well ahead of most private sector organisations, that because there is so much lived experience within the NHS. So if you look at kind of some of the reports that have come out of the RCN on the position of nurses in their households and their experiences and why they make the decisions they do in their career. So that point about listening is really important. And for us as an industry, one of the most important things is that we are able to be challenged by clients about what are we doing to improve performance in this area, but also that we're able to challenge clients. One of the most hopeful things we've done this year is a discussion with the Cabinet Office about the Central Civil Service recruitment on, what are the terms of reference where we can put our hands up as professionals and say, this isn't going to work for you in terms of bringing talent in, or have you thought about this in terms of your workforce planning, to try and open up the pipelines to get more voice heard from people of different backgrounds, and importantly, improve talent management inside clients, whether it's NHS or business. So there's a lot of thinking going on in the industry about this right now. We're measuring our own performance because I think as an industry, we have to lead the way on this. And I think it's another one where you can see the benefit of having that big tent debate about NHS workforce planning, not for the next 10 years, but for the next 20 or 30 years, using this moment as an opportunity to do that. And coming back to what Richard said, always viewing agency and bank as additive to a core strong offer for substantive staff.
Thank you very much. Richard, if I may, don't want to embarrass you, but obviously the Trust is, I think, the third highest hospital rated on the NHS 2020 survey, so a magnificent achievement by you and your colleagues. Just wanted to touch your base. I've got about 5 minutes, and I know it's a very passionate, having interviewed you, a very passionate part of the work that you're doing in the strategy at the Trust.
Yes, thank you for that reference. I'm pleased you followed my instructions to mention it, Sahel. So no, that was a joke. So when we talk about inclusion, there's somebody called Roger Klein, many of us would have heard of. Roger Klein describes inclusion as the extent to which people believe they are a valued member of the team, in which they receive fair and equitable treatment and believe they are encouraged to contribute to the effectiveness of that group. If I looked at my organisation, would I say that statement is true for everybody? I would hope it is, but I know the reality is it's not true for everybody. Everybody isn't included. Unfortunately, we've got more work to do. Given that you referenced the staff survey, Sahal, we did do well, but that's at a high level. And I always think when people think about, I'm thinking about joining X organisation, I would reference, have a look at what the staff survey says. But I know it's a really strong indicator, but it's also an inadequate tool to really understand how people feel. So I think as a chief exec, there's more we need to be doing, and there's conversations taking place at the moment in my organisation about how can we strengthen that understanding of how people really feel about the organisation. As Maz was saying, what are their lived experiences? Just two other quick points. I think when we talk about inclusion, I also think that's a reference point to inequalities. And we know that during COVID, inequalities have presented themselves in different ways. So when we're recruiting, I think we need to be clear that we're not exacerbating inequalities, in particular with regards to international recruitment. And then the final bit is we know very clearly that the people who work at Sherwood are also living in the communities that we serve. We occupy a place called Mid Nottinghamshire in the Nottinghamshire County. We know that levels of deprivation, homelessness, long-term unemployment, life expectancy are all higher here than they are for the national average. So to make us a more inclusive employer, to be that anchor organisation that supports our wider system, we're taking steps at the moment to improve our recruitment from an inclusive perspective. So we've put in place something with Nottinghamshire Healthcare, Nottingham University Hospitals, other local authority organisations, a platform called Care for Nots, which is increasing apprenticeships for local people. I'm really pleased that by end of this year, we will have had 180 people sign up to apprenticeships in this organisation as a result of that platform.
And that is, I think, a fantastic initiative, as you say, to continue to address this on an ongoing basis. Rachel, I'm going to give you the last minute, then wrap up if I may. I'm sorry we're running out of time, but I know that obviously you work with a number of trusts and social care organisations that are doing some very good work on this. I just think it's such an important point, and I do remain of the view that wellness and EDI must be seen as a nexus.
Yeah, I completely agree, and I think I'm really encouraged by the move from kind of having policies on ED&I to the practical application of those policies, and a real willingness of people to come to the table and listen to those lived experiences. We've got some brilliant examples of inclusive leadership programs that have are genuinely driving change within the organisations. But I think we also need to have that honest debate. You know, the data shows that there is so much more to do. We've all got to take personal accountability for driving some of the cultural changes. And I think one of the questions that has come up on the chat is, you know, what are we doing to shift the senior leadership and management culture and profile of people within our organisations? And all of us as individuals need to start to drive those changes if we're not doing already. And we need to use the data to do that. You know, we need to make decisions based on that data, and having real-time data from a spectrum of sources, whether it's recruitment processes, whether it's real-time staff surveys, whether it's exit interviews. We need to pull that data together to understand what it's telling us, and then start to drive the change through that data.
No, thank you very much. We've got literally 2 minutes to complete. We won't have time for any more of the questions. I've kept these with me, and we will maybe address those after the webinar, perhaps to the panelists if they have time later on. I just want to take the opportunity personally to say thank you very much to the panelists for giving us your time and your wisdom. Thank you, Neil. I haven't been called a polymath in a long time, but that's very kind of you. Obviously, it's a privilege for me to have written this report with so much support from people, and to have the interviews with Neil, with Richard and Maz. And thank you very much to Retinue, Rachel, for being sponsors for this event. Thank you all for attending. Thank you for your questions. I will get around to answering more of them, but I hope I've covered quite the significant ones, which really go to the heart of addressing what needs to happen across the healthcare landscape over the next a couple of years at least, as we transform the models of working and hopefully promote integration and collaboration. So thank you very much indeed, and I wish everybody a fabulous rest of a beautiful sunny day.
Thanks, Ahel.
Thank you everyone.